So our next speaker is Dr. Maritalia Ramirez-Fort, and she is the president and CEO of BioFort in Puerto Rico. And she has earned her undergraduate degree at Lehigh University and medical degree at Ponce Health Science University, where she also completed a general surgery internship at the University of Pittsburgh Medical Center. And since then, she has trained in radiation oncology at the Medical University of South Carolina, jointly with a postdoc research fellowship in urological oncology at Weill Cornell Medicine. She now serves as president and CEO of BioFort, a privately owned corporation, which is headquartered in Puerto Rico, and that is dedicated to the advancement of science. And she is also a voluntary visiting professor at the San Juan Bautista School of Medicine in Puerto Rico. And she has authored more than 70 peer-reviewed articles, abstract and book chapters, and she's going to be talking, her current research interest involves the use of electromagnetic radiation within the UV waveband to inactivate SARS-CoV-2 and other viruses in infected tissues. And today she's going to be talking about just that. So narrowband UVB may inactivate SARS-CoV-2 in infected tissues. So thank you very much for joining us, Dr. Ramirez-Fort.
Okay, I really apologize for the technical issues, and I want to say thank you for that very nice introduction and for starting my talk. So my talk is about the possible use of narrowband UVB in the treatment of SARS coronavirus 2 that is already in tissue. And so I'm going to start with talking about the observations that us as physicians have made over the past 2 winters that we've had this coronavirus pandemic. And what we've noticed is that during the winter time, mortality and coronavirus air contamination increases. We've also noticed that this is particularly true in the northerly and southerly latitudes. And it's also true in the crowded indoor areas. And so what these 3 points have in common is that each 3 is associated with decreased ultraviolet radiation. Now, there is a model that very nicely shows the importance of UV radiation in inactivation of virus and maintaining lower viral loads in the ambient areas. And that's the Sagre-Panty and Lytle model. And that model has already been applied to SARS coronavirus 2, and it predicted that SARS-CoV-2 is 3 times more sensitive to solar UV than influenza virus. It also predicts that it could take as little as 11 minutes of solar UV to inactivate 90% of virus in ambient air during the summer, while it can take more than 300 minutes of solar UV to inactivate the same amount of virus in ambient air during the winter. And this is dependent on the geographic location. Oh, next. So Sagre-Panty and Lytle also demonstrated something else that I think it's important to highlight so that we can understand the importance of ultraviolet radiation in maintaining low viral ambient loads. And so what they showed is that it's not the temperature that reduces the viral load, it's actually the solar UVB that inactivates SARS coronavirus 2. And so they conducted this very elegant experiment. And they showed that when they took vaccinia virus, put it on ice, and exposed it to direct sunlight, then measured the log reductions of viable remaining virus, that it was in fact just the UV and not the warming effects of the sun that resulted in meaningful virus inactivation. And since then, they have repeated the same experiment in multiple other viruses, and now we can assume the same is true for SARS coronavirus 2. Next. So now let us connect solar UVB to narrowband UVB in clinical dermatology. Next. So narrowband UVB is available probably in every dermatological practice across the globe. And it's something that's prescribed as a surface dose, that's in millijoules per centimeter squared. And the clinical efficacy and safety of this treatment modality has already been shown in a variety of skin and mucosal microbial infections, including viruses. Next. So this is probably one of the most important slides in my entire presentation, and I want to show you a case report by Zhang et al. And he demonstrated that 300 millijoules per centimeter squared in 12 fractions over 4 weeks cured cutaneous human papillomavirus infection in a pediatric patient. Next. So now I'd like us to build a bridge between what is dermatology and what is radiation oncology. Next. So when I saw that case report, I thought, could narrowband UVB also reduce the viral load of other viruses and perhaps other tissues? And if so, to what depths might we treat? And what exactly is the sensitivity of SARS coronavirus 2 to UVB? Next. So before we try to answer my questions, it's important to differentiate between ionizing radiation and what is narrowband UVB radiation. So ionizing radiation is measured in the units of joules per kilogram squared, and that's a volume, while narrowband UVB is measured in the units of millijoules per centimeter squared, which is an area. Now, ionizing radiation is prescribed as a dose to a depth in volume of a tissue, and that is termed the depth dose, while narrowband UVB is prescribed as a surface area dose, and the narrowband UVB depth dose in tissue has barely been defined. Next. Best probable data that I've encountered was actually done by Kuhil et al. In 1984, and I think there was an update in 1990, which is depicted in the table to the right. And so he performed UV depth dose calculations for both 300 nanometers and 350 nanometers, and found that 40% and 65% of the prescription surface dose reached a depth of 50 micrometers in mammalian tissue. Next. So when we interpolate the depth dose between 300 and 350 nanometers, we find that in the narrowband UVB wavelengths, so that's 310 or 311 nanometers, about 44% of the surface dose reaches a depth of 50 micrometers. And that's important, and I'd like you to remember that, but I'll remind you later. Okay, next. So now I'd like us to build another bridge and connect the Sagrapanti and Lytle model to clinical dermatology and clinical radiation oncology. Next. So in that same model that predicted that coronavirus is 3 times more sensitive to the sun than influenza, they also estimated the dose required of solar UVB to result in 10% virus survival or 1 log reduction, and that dose was 6.9 joules per meter squared. They also calculated that to reach a 2 log reduction, they'd need a slightly bigger dose, which is 28 joules per meter squared, and that's to account for, to overcome shielding by the organic material that might be in the environment, anything that would put itself between the sun and the virus. And so if we just take those doses in joules per meter squared and translate them into the units that are used for narrowband UVB, we find that approximately 1 millijoule per centimeter squared is needed for a 1 log reduction to a certain cell layer depth within mammalian cells at that depth. And the same would be true for 3 millijoules per centimeter squared to result in a 2 log reduction of mammalian cells at a specific depth. Next. So now we've connected surface area dose to a depth dose and the sensitivity of SARS coronavirus 2. So I'd like us to practice that clinical thought. Next. And I'd also like us to start thinking about, well, if we were going to treat tissue that was infected with SARS coronavirus 2, what would be a reasonable surface dose to achieve the therapeutic gain? Next. So back to our pediatric patient case of a successful cutaneous HPV infection cured with narrowband UVB. Next. So first we need to determine the treatment volume. What is it that we are trying to treat, or that we did successfully treat in this case? And so we know from the pathophysiology of HPV that it infects the basal layer of the epidermis and slowly moves its way up. And so we would expect that, given that the face in that patient can range with a depth from 30 to 60 micrometers, but that the area of the forehead and cheeks is usually around 45 to 50 micrometers, that the depth we're trying to treat in that patient was 50 micrometers. Next. And I'd like to remind you that we previously calculated that 44% of narrowband UVB surface dose reaches a depth of 50 micrometers. Next. So if we prescribed a dose of 300 millijoules per centimeter squared to an epidermal thickness of 50 micrometers, we would expect and can assume that the depth dose of 50 micrometers is 131 millijoules per centimeter squared. And if we multiply that dose by 12 fractions, then we can say, wow, HPV in tissue is cured with a cumulative surface dose of 3,600 millijoules per centimeter squared. Or we can also say that HPV in tissue is cured with a cumulative dose of at 50 micrometers of 1,572 millijoules per centimeter squared. Next. So let us maintain these bridges and now transition from HPV to SARS coronavirus 2 in tissue. Next. All right, so here is the histopathology of a tracheal epithelium, and from this I just want it to be understood that if we were to treat tracheal epithelium with narrowband UVB, we would be aiming to treat at a depth of less than 50 micrometers. And I'd also like you to remember that we had previously estimated that 1 millijoule per centimeter squared is needed for a 90% reduction of virus, while 3 millijoules per centimeter squared is needed for a 99% reduction of virus. Next. And I also want you to remember that 44% of narrowband UVB surface dose should reach a depth of 50 micrometers. And I also want you to assume that all trachea epithelial cell layers will be irradiated if we radiate to a depth of 50 micrometers. So if we combine our hypothesis with the interpolation of Coohill's depth dose data, then we find that 30 millijoules per centimeter squared, that is 10 times less what was used in the pediatric patient to treat HPV in tissues, results in a depth dose of 13.1 millijoules per centimeter squared at 50 micrometers. So what this means is that with just 30 millijoules per centimeter squared of narrowband UVB, we may achieve at least a 4-log reduction, or 99.99% reduction of SARS-CoV-2 in tissue up to a depth of 50 micrometers with just 30 millijoules per centimeter squared. Very small dose. So what have we identified? So we found that perhaps narrowband UVB is a viable therapy for the inactivation of viruses in tissues, including SARS coronavirus 2, that 44% of narrowband UVB surface dose should reach a depth of 50 micrometers in tissue, and that the depth dose of 30 millijoules per centimeter squared at a surface prescription at a depth of 50 micrometers in tissues is 13.1 millijoules per centimeter squared. And our calculations suggest that 30 millijoules per centimeter squared may achieve at least a 4-log reduction or 99.99% reduction of SARS-CoV-2 in tissues up to a depth of 50 micrometers. But of course, before implementing or experimenting, we really need further studies with direct dosimetric measurements to confirm and validate our calculated depth doses and hypotheses. So I want to thank you from our entire team, or part of them. And with this, I conclude my talk.
Thank you so much. We're clapping. Thank you so much, Dr. Ramirez. And so a question also for Dr. Ramirez. This was a very interesting talk. And when we talk about UV as dermatologists, we don't really see it as a friend. It's more of a foe, really. So it's interesting seeing you talk about it as a helpful, radiation. So one of the things I was I was curious about is how are you going to manage the risks of exposing, non-melanated tissue to UV? Because I mean, if you're going to expose, as I understood, maybe the respiratory tissue to UV, even small doses, if there is no melanin in the system, they're not protected. So from the deleterious effects of UV, specifically the UV signature mutations. So I don't know what's your thought on that, and what are the safety concerns of this potential therapy?
Well, thank you for your question. That has to be defined still. There is very little data of, for example, mucosal survival curves after UV radiation, but there is data on the LD50 of mucosal cells exposed to narrowband UVB, and there is a single paper that looked at irradiation with 105 millijoules per centimeter squared and found that with their assay they weren't able to detect any damage to the cells. So of course, based on the LD50, I think that one could have expected up to 17% damage in that cell population, and perhaps that the irradiation to the 105 millijoules per centimeter squared just couldn't detect it with the assay that they had. So based on that information, I'm thinking, well, the dose that we are proposing that's needed to inactivate SARS coronavirus 2 to 1 to 4-fold, depending on how deep we want to go, is 10 times less than what was already used in a pediatric patient, and it's more than a third lower than what was used to irradiate mucosal cells, and no damage was seen. So I think the real question is not so much of the dangers of irradiating non-melanated tissues, but more so how we should fractionate the narrowband radiation of tissues that have a viral load of SARS coronavirus 2. And I also think it's important to look at the risk versus benefit. Stochastic effects of radiation show up 20 years later, but if someone has a very high viral load and has organ systems that are highly charged with SARS coronavirus 2, then what we really want to do is, listen, if one fraction can reduce 90% of the virus in that tissue, that's better than any of the current antiviral drugs we have out there that are reducing maybe the overall body viral load by 30%. So, I mean, there's a lot to be learned, and clearly preclinical studies are what will help us define this. But I think the thought is important, and to reason it out more so by the experts that know how to use narrowband UVB effectively is going to be even more important.
Thank you so much. That's really very interesting. Thank you.